Yeah. So we shall now go on to Dr. Lakshmi, who's going to tell us something very, very relevant, failed DCR, evaluation and management. On to you, Doctor.
Thank you, Dr. Chitra. Can you see my screen?
Yeah.
Thank you for organizing such a useful and wonderful webinar, and Dr. Arvind for beautifully moderating the whole show. There's so much to learn and there's so much more to tell, but let me tell you that each and every single speaker has answered most of what I'm really going to mention. Possible causes are very many previous of failed DCR, previous sinonasal surgery. They might have had FES surgeries, failed probings, mid-phase trauma, tumors, patients uncooperative to a proper clinical evaluation. So you really don't know what's happening. You're assessing the patient on the table, which is not good, anatomical variations, and you're not very sure as to why the epiphora started at all. Now there are various causes, congenital, it's very clear, probing and massage works 90% or more, and the few cases which need DCR, make sure that they don't go in for an abscess formation. And if there's an abscess, it's a bit better to admit the child, give intravenous, and treat just as you would for an orbital cellulitis. So good technique of probing and syringing using an infant nasogastric tube to retrieve the fluid, or even those small tips for during anesthesia where you keep the head little lower down, make sure as much doesn't go into the passages, throat, etc. And the proper knowledge of the anatomy is most important. This is a child who had a stenting in the US with probing. I don't believe in fracture of the inferior turbinate. It is causing more trauma to a problem which is already existing. They were not sure whether the stent was there or not. So here CT-DCG, I cannot overemphasize, plays a very valuable role in delineating what is exactly happening, because 2 or 3 failed probings, the parents are very anxious. You don't want to land up in trouble. So know what is really happening before you go for a DCR or a revised DCR. Tip 2, we started wearing masks with shields long ago, many years back. And with COVID now, all the more the reason why you should wear thorough clinical evaluation is a must. Thorough anatomy and ENT evaluation. In each and every single case, I get ENT evaluation. This is my tip number 3. So failed DCR, usually it is sinusitis which has not been picked up. See, you are making a beautiful passage, as Shruti Tara beautiful showed an excellent. If the milieu inside the nose is no good, what's the point in making a good ostium? So get a good imaging done, and if there is a doubt, X-ray is not enough, please go for a CT scan or a CT-DCG. CT-DCG we started almost 20 years back. You can do a drop technique or a syringing technique. See, you beautifully know, see here it is blocked. Though the DCT has been done, there is a sac there and it's not going through. So there's a block. Here the sac has emptied and it has gone down. The dye has gone down. So it's such a nice way of delineating. Again, in the duct, you don't see the dye in the duct. Here you can see the dye. So both axial and coronal and even reformatting sessions are there now, which are very useful. The radiologist can play very many things on their system and they can help you. Adjacent paranasal sinuses, adjacent fractures, any bony details or anatomical variations can be picked up. Sometime in 2010, failed DCRs and traumatic NLD obstructions were the main indications why I got CT-DCG done. And they had 13 patients out of 25 had associated sinus disease, which was not picked up or treated. So, and 15 patients underwent surgery, and the intraoperative findings correlated with the CT-DCG findings. So it's very helpful. Masses, if you carefully put in a Bowman's probe and excise the mass, you will not damage the canaliculus or the sac, but many a time it can happen. So this has to be recognized. So, and even for other surgeons who are dealing with tumors in this area or reconstruction, it's very important to make sure that the nasolacrimal system is working well. What's the use of putting a good implant or a graft or a flap there if you have underlying infection or subsequent infection? So this is what happened. Here there is underlying infection and she had a beautiful flap for an inverted papilloma, but there was a discharging sinus, same as in this case. So this has to be recognized. And as one speaker pointed out, these can be medico-legal issues as well. And this patient went for a routine MRI for a headache and he was noted to have a lacrimal sac mass. So this, we did a CT-DCG, made sure that there was no communication with the sac, and even intraoperatively, while we're excising that mass there, which was just an inclusion cyst, the sac did get damaged, and a DCR was also done. Prior permission was taken. In trauma, recognition is very important of the lacrimal system injury, but of course, ABC is very important, airway, breathing, circulation, much before you analyze what's happening to the eye. A thorough investigation is needed. Anatomical consideration, see what's happening to the bone, soft tissue. Usually there's a traumatic telecanthus where the lacrimal sac gets displaced along with the medial part of the bone there. So it's not very easy to work with damage or trauma in the medial canthal region. And you should realize that the mid-face is the weakest portion. So mid-face trauma is very, very, very prone, and nasal trauma, you're more prone for lacrimal sac injury. So you have telltale signs, xenophthalmos, rounding of the medial canthus, so many things. And of course, you can always, once you identify the punctum canaliculus, do a thorough clinical evaluation. And when in doubt, please go for, anyway, the patient needs an imaging. They will need a CT scan with 3D reconstruction. Might as well do a CT DCG also in the same sitting. So this, you see, here it looks hardly anything sinister there. But when I explored the wound under GA, just see, the clot gave way and I have a huge gap there. Luckily, I had taken consent for DCR and proceeded. Whereas on the right side, which looked a little more deep, but on the table, I just cleaned the clot. It was not, nothing was in the sac was not involved. So thorough evaluation is an important aspect. And of course, you must have your other colleagues, the cornea colleague and the retina colleagues, because any intraocular injury, you should tackle that as well. Or if in case that is more severe, finish that first and then take care of the sac. So primary repair, secondary repair, all this intubation and all that has been discussed. But in an important thing, when you work with maxillofacial surgeon team, please request them not to put the plate right up to the medial aspect, where they can damage, sometimes an iatrogenic damage of the sac can occur. So this should be avoided. And if you are dealing with a later problem, make sure the imaging is done. And if the plate is extending right up to the medial wall, this has to be removed before you do the DCR surgery. See, this is another case where this plate was going right up to there. And see, this is a traumatic telecanthus rounding. And even after intubation, she's not very happy. Patients are not, here there was a trauma with a bulgur injury, a callus had formed. So an external DCR had to be done along with an endoscopic DCR, because in the endoscopy, all this bone could not be debrided. Early canalicular repair, we all would agree, gives the best results. And these days, the monocanalicular stents, especially the ones which are coming from Arvind Eye Hospital, are excellent. They have got very good results. So if there is an associated fracture, please do the DCR surgery first, then tackle with the orbital fracture. If there is infection, no point in putting an implant or a bone graft or whatnot. Same. So just deal with the, Dr. Chitra already asked me, so if there's a soft tissue repair, deal with that first, then take care. But of course, whatever you do, the canaliculus can never get back the full integrity unless you've done a good primary repair. However well you do, some amount of defect will be there. So try to repair the canalicular region with an intubation or a monocanalicular stent in the first sitting itself. Even if the other canaliculus is intact, if it's a young patient, please go ahead with repair in the primary sitting. And of course, in elective cases, if there is very acute abscess, prefer not to drain. And if it's a recurring infection and you're planning an elective DCR, please take care of the infection first. You may need to give them even intravenous antibiotics. And this patient begged me because his marriage was coming up to do cosmetic surgery, but he had a discharging sinus. So we had to do a good DCR first, then the orbital fracture was subsequently taken care of. So post chemotherapy, I find a lot of patients don't do very well because of the reduced stretchability of the skin. Sometimes post chemotherapy, when you do a DCR, they can come back with recurrence later on because of reduced healing. Also diabetes, bleeding tendencies we have already discussed, and poor patient compliance. And canaliculitis, I can't overemphasize. You have to pick it up. Everything is not such straightforward like this. You have to pus, let out all the pus, do repeated flushing. I don't believe in this one single snip technique, 2 snip, 3 snip. I think in 32 years, I have done only one in sometime in 1996 and gave it up after the first case. I don't believe it. Javed also mentioned that he also doesn't try to express all the contents. We don't get scephazolin, but you have other alternatives now. These are the main organisms, actinomyces and nocardia. And every time after flushing in the OPD, it takes about 2 to 3 months for the infection to clear. We reconstitute the drops and give. I leave behind some ointment inside the canaliculus. So that also helps. Punctal stenosis is invariably after a viral keratoconjunctivitis or a viral conjunctivitis. So elicit that history. This patient developed this stenosis after viral conjunctivitis. So you initially just try to dilate and open up. Don't allow it to go completely into a contraction or a stricture. So the key is that, and if not, leave a monocanalicular stent. Of course, Stevens-Johnson's and other conditions, skin conditions are really a headache to treat because of the associated anterior segment issues. But of course, you try your best. Repeated dilatation of the punctum and syringing is what I do. I don't try to put in stents or tubes at all in the first sitting. Very rarely I put in stents, only if it is needed. Suspect fungal infection in patients who are diabetic or immunocompromised, and all the more now with this COVID issues. Be careful while using powered instruments in lacrimal surgery, especially endoscopic DCR. And if you are working with an ENT surgeon who's very fond of powered, and see what happened, these powered instruments pulled on the medial rectus and optic nerve. The patient was NPL on the table. You don't want this disasters. Leave alone loss of the eye due to the infection. We have rare cases where the pus goes behind, and due to NLD obstructions and lacrimal sac abscess, loss of vision. I've seen about 3 cases, but use of powered instruments, I think nobody will forgive us. They will only sue us. Good nasal decongestion before surgery and a good nasal packing, you can't overemphasize. In fact, I used to do some DCTs long back in the past, but once I learned endoscopic DCR sometime in 96, I have not looked back. I have hardly done DCT except in very rare cases, as Mohan mentioned, for tumors. It's only DCR, and my anatomy knowledge improved after doing endoscopic DCR and external DCRs. I again am a strong believer of 2 flap techniques. Like especially when Shruti showed her beautiful video, I really hope she didn't excise the posterior flaps because she had wonderful both lacrimal sac and nasal mucosal flap. If you can give instant mucosal lining there, nothing like it, Why go and excise the posterior flap and leave bare bone and allow it to granulation tissue will become more. And you can't say stop breathing. You are going on breathing. You are going on having all the insults there. So it is naturally profound recurrence. So if you can give instant mucosal lining, nothing like it. Avoid DCT. This is a patient who came to me with repeated infections after 2 DCTs. And I opened up, I salvaged some amount of sac tissue and did a DCR. A big ostium. Textbooks say 1 centimeter. It's not enough. You need at least 15 millimeters to 18 millimeters of ostium, because the beautiful work which was done earlier endoscopically, when you see them after 3-4 months, you have the ostium starts shrinking. So at the end of the day, if you have about 3 to 5 millimeter, you're really very lucky. Even if you have a 1 millimeter ostium which works, it's fine. Now again, even after that, I realized the patient has 100% patency after DCR now, after 2 DCTs, but still he's getting an abscess. I analyze the pus, he's going E. coli. It's so embarrassing to tell the patient you are having contamination, from your feces or urine or whatnot. It's very embarrassing. And this is a strange, usually it's Staph aureus, but he's growing E. coli and maybe he has some amount of cellulitis. So if you can do a good DCR, please do a DCR and avoid DCT even in camp patients at any cost. Thank you very much.
Thank you very much. That was a amazingly wonderful talk. I mean, we kept the best for the last.
No.
So much.
The youngsters.
It was really nice talk. Yeah.
Covering all so much from them.
Yes.
Yeah.
So I think we are a little late. Arvind, would you want to take some questions before we conclude a very absolutely wonderful webinar?
I'm always amazed by Dr. Lakshmi's enthusiasm to teach and her eagerness to share her years of experience. And then she's been through all these. She's been in an institution. She's been in a private institute. She's converted from external to endoscopic DCR.
Not really. Not really. I do where it's needed external. I do where it's needed endoscopy, and I get mainly, I shouldn't say sorry, Kachida cases. So, and I am not good as Javed to do the septoplasty. So I do take the help of an ENT surgeon for septoplasty alone.
I also do. Yeah. Ma'am, it was very nice talk. We are very, very, very grateful to Dr. Chitra ma'am and Dr. Arvind sir.
I can't thank Dr. Chitra and Dr. Arvind enough.
I would also like to put on record Dr. Chitra's meticulous planning in choosing one surgery for an entire webinar and the choice of topics. I mean, they're as diverse and still as comprehensive for this particular surgery. And she has sat through the entire thing. It's probably like us, a DCR surgeon, sitting through a refractive surgery symposium and asking very relevant questions. So thank you very much for the opportunity, madam.
Yeah. All ARC you attend in, you see that she knows everything.
Yeah, Arvind, the only difference is that Madam Chitra Madam has been asking relevant questions.
Yeah.
If we sit through a refractive symposium, we'll ask tougher questions to them.
Yes,
Very true.
I think Dr. Chitra sits through all these meetings.
She's really through it.
I think she's become an institution by herself. The only thing I see is, despite all the publicity, all the hard work, the number of participants is what we have been talking to each other, isn't it? That's the unfortunate part. But I think that's fine. I mean, one motivated listener is better than a hall of 1,000.
Why are you saying that? I'm going to tell you how many watch. This is a little focused. Oculoplasty might have less attendance, but even then, attendance is good in these webinars. I think if I reach to 300 in this, I would be very happy. Of course,
and many watch it later. I have seen that.
It has gone, many of the webinars have gone to 1,000, 4,000, 5,000.
With time, people are not free.
Have contributed to a library for ARC, and that's so amazing. And I think, as I give my concluding remarks, I need to thank every single expert panel here for being with us, giving such volumes of information, the quality of speakers who are there in this particular meeting, and the kind of information which came through. It's not that it's my level of tolerance which made me sit. There was no way I was going to get up and go when so much was being poured over to me. And I think anybody who is not going through any of the other ARC webinars, it is their loss, because each of you have spent 2.5 hours and so much more time in preparing these talks. So kudos to one and all of you. At this juncture, I need to thank Dr. Arvind, who came up with such relevant, precise questions, and he's beautifully steered the webinar that I could even go and take some of those one-odd phone calls which happened in between. Kudos to you, Dr. Arvind. I need to definitely thank my ARC team who are always there with me, always supporting me in all my ventures. I need to thank Kripal and the AIOS admin for the SMSs which come and the kind of encouragement they give. Thanks to Sai and Manjula from Neurotech for all those mailers which come to you. I actually never actually thank, and this is the first time I need to thank that young boy, Vel Murugan, who makes me realize all that I have wanted to do for ARC in these last 2.5 years. And I have to thank Encode for being that solid support for me and sponsoring all these ARC webinars of ours. And don't you think all of us in unison have to thank Mr. Sunil, who also keeps hearing all these webinars, who's our webinar admin. Thanks a lot, Mr. Sunil. And finally, I think we need to thank attendees for watching, and I'm sure they have gained. And I'm sure I'm the take a break, which I'm going to keep bringing in every week, would now onwards, or rather it has already started, would have a webinar clip also coming along with it. So people who have missed the earlier webinars, and if it is relevant to the subject, they could click and watch it too in case they don't access the website. Thank you very much, one and all of you. Thank you.
Thank you.
Thank you.
So much.
Thank you so much.